بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. طلاب الأعزاء، معكم دكتورة فاطمة ديب، مدرس الأمراض النفسية، قسم الأمراض النفسية والعصبية، كلية الطب، جامعة طنطا. النهاردة هنتكلم عن محاضرة Gender and Human Sexuality. هدفنا نفهم Normal and Abnormal Human Sexual Practice. هنبدأ definition of terms, development of gender identity, human sexual response cycle, and overview of sexual disorder. Definitions: هنعرف sexual identity يعني ايه، gender identity and gender role and sexual orientation وايه الفرق ما بينهم كلهم. Sex versus gender. Sex, the state of being biologically male or female, also sexual activities. Gender refer to a broad set of characteristic qualities that distinguish between masculinity and femininity and include personal attributes, social rules, social customs, activities, and behavior. Social activities may change according to culture by time. In simplest terms, sex is biological while gender is sociological. Sexual identity: biological characteristics that divide individual into male and female categories. Sexual identity is based on the person's sexual characteristics such as external and internal genitalia, hormonal characteristics, and secondary sexual characteristics, chromosomes, XX versus XY, external genitalia, internal genitalia, hormonal composition, gonads, and secondary sexual characters. Gender identity. Gender identity is based on the person's sense of maleness or femaleness and is established by age 3 years. Gender role is based on the external behavioral pattern that reflects the person's inner sense of gender identity or the social behavior that allows others to categorize the person as male or female. Gender identity factor of infancy and childhood. Distinguishable female or male sex organ leading to child own body image leading to child core gender identity. Also, distinguishable female or male sex organs leading to sex assignment at birth leading to rearing of child as girl or boy leading to child core gender identity. Male and female sex dimensions and gender dimensions. Sex dimensions according to chromosomes, gonads, hormones, external genitalia, internal accessory organs, secondary sex characteristic, sexual orientation. Gender dimensions: gender identity, self-definition, perceive self as male or perceive self as female. Gender role, society expectation, masculine, boys like track and sport, or feminine, girls like dolls and clothes. Sexual orientation is based on the person's choice of love object: heterosexual, opposite sex, homosexual, same sex, bisexual, both sex, asexual, no sex. Homosexuality was removed from the DSM system in 1980 as a mental illness. It is considered as a variant of human sexuality, not a pathologic disorder. Most homosexuals report feeling toward same-sex individuals since adolescence. Recent studies indicate that it may be due to genetic and biological causes. Greater incidence among monozygotic versus dizygotic twins. No difference in the sexual practice from those exhibited by heterosexuals. Male to male relationship may be less stable than female-female relationship. Equal incidence of mental illness when compared with heterosexuals. Exceptions: normal homosexuality may be normal during adolescence. Visual comparison of genitalia, mutual masturbation, group exhibitionism, hand holding, kissing, and so on. Masturbation. Masturbation is a normal precursor of object-related sexual behavior. Nearly all men, 90%, and half of women, 50%, masturbate. Genital self-stimulation begins in early childhood. As puberty arrives, sexual interest peaks and masturbation increases. Adolescent and adult typically have sexual fantasies while masturbating, commonly seen among adolescent, married couples, and the elderly. Excessive only if it interferes with daily functioning. Sexual response cycle. Masters and Johnson describe human sexual response to consist of 4 phases. Phase 1, excitement. Phase 2, plateau. Phase 3, orgasm. Phase 4, resolution. Diagram explaining the male sexual response cycle. Diagram for explaining female sexual response cycle. Phase 1, desire or appetitive phase, characterized by sexual fantasies and desire to have sexual activity. Desire or thought or fantasies or erotic feeling. Sexual arousal can occur with or without any sensory stimulation through thoughts and fantasies alone. Stimuli that people find arousing is greatly influenced by cultural conditions. Features that are considered attractive vary from one culture to another. It is under the control of cerebral cortex, limbic system, nervous system, and endocrine system. Brain areas involved in sexual arousal and response. Cerebral cortex, responsible for thinking center of the brain. Limbic system, associated with emotion, motivation, and also includes the pleasure center. Hormones and neurotransmitters involved in sexual arousal and response. Hormones. 2 hormones, testosterone and oxytocin. Testosterone, sexual desire in both male and female, stimulate dopamine release. Oxytocin, increase skin sensitivity to touch. High level are associated with orgasm. Level remain higher after orgasm, thought to contribute to emotional and erotic bonding of sexual partner. المودة والرحمة في هذه النقطة. 2 neurotransmitter. Dopamine, released pressure center of the limbic system, facilitate sexual arousal and response. Serotonin, inhibit both dopamine and sexual activity. And this diagram showing us that testosterone is stimulant for dopamine and so the desire. Estrogen and progesterone also stimulate desire, but serotonin and prolactin inhibiting the desire. Disorders of desire. Male hypoactive sexual desire disorder, characterized by a lack of interest in sex and a little sexual activity. Physical response may be normal. Female sexual interest or arousal disorder also lack normal interest in sex, rarely initiate sexual activity. Many experience little excitement during sexual activity, are unaroused by erotic cues, and experience few genital and non-genital sensation during sexual activities. Causes of excitement disorder: biological, hormonal, vascular, drug-induced; psychological, fear, performance anxiety, anxiety and depression; socio-cultural, attitude, fear, and psychological disorders that contribute to sexual desire disorder occur within a social context. Culture standard can set the stage for development of these disorders. Trauma or assault: sexual trauma or assault is especially like to produce disorder of sexual desire. Phase 2: excitement. Neurotransmitters influence this stage: cholinergic nerves, adrenergic nerves, vasoactive intestinal peptide VIP, dopaminergic system in CNS facilitate arousal, vascular mechanism. Disorders of excitement: two dysfunction affect this phase: female sexual arousal disorder, formerly that is to say frigidity; male erectile disorder, formerly called impotence. Male erectile dysfunction, characterized by persistent inability to attain or maintain an adequate erection during sexual activity. This problem occurs in as much as 10% of general male population. According to survey, half of all adult male have erectile difficulty during intercourse at least some of the time. Cause of excitement disorder: biological, hormonal, vascular, drug-induced; psychological, fear, performance anxiety, anxiety and depression; attitude, fear, and psychological disorders that contribute to sexual desire disorder occur within social context. Cultural standard can set the stage for development of these disorders. Sexual assault or trauma is especially likely to produce disorder of sexual desire. Phase 3: orgasm, peaking of sexual pleasure and release of sexual tension; pelvic contraction and ejaculation. Disorders of orgasm: there are 3 disorders of this phase: early or premature ejaculation, delayed ejaculation, and female orgasm disorder. Premature ejaculation, characterized by persistent reaching of orgasm and ejaculation with little sexual stimulation. As many as 30% of men experience rapid ejaculation at some time. Psychological, particular behavioral explanation of this disorder have received more research support than other explanations. The dysfunction seem to be typical of young sexually inexperienced men. It may also be related to anxiety, hurried masturbation experience, or poor recognition of arousal. Delayed ejaculation, characterized by a repeated inability to reach orgasm or by a very delayed orgasm after normal sexual excitement. Of the male population, 8% occur. Biological causes include low testosterone, neurological disease, head and spinal cord injury. Psychological cause may be performance anxiety. Female orgasmic disorder, characterized by persistent delay in or absence of orgasm. Most clinicians agree that orgasm during intercourse is not mandatory for normal sexual functioning, typically linked to female sexual arousal disorder. The two disorders tend to be studied and treated together. Once again, biological, psychological, and socio-cultural factors may combine to produce these disorders. Causes of orgasm: female orgasmic disorder, biological causes and psychological causes. Biological causes: a variety of physiological conditions can affect women's arousal and orgasm. The same medication and illegal substance that affect erection in men can affect arousal and orgasm in women. Postmenopausal change may also be responsible. Psychological cause. The psychological cause of hypoactive sexual desire and sexual aversion, including depression, may also lead to female arousal and orgasmic disorder. Memories of childhood trauma and relationship distress may also be related. Causes of orgasm, female or orgasmic disorder. Socio-cultural causes. For years, the leading socio-cultural causes or theory of female disorder of sexual desire was that it resulted from sexual restrictive culture message. The theory has been challenged because sexual restrictive histories are equally common in women with and without disorder. Culture message about female sexuality have been changing while the rate of female disorder of sexual desire stays constant. Researchers suggest that unusually stressful event, trauma, or relationship may produce the fears, memory, attitudes that characterize these dysfunction. Research also linked orgasmic behavior to certain qualities in a woman's intimate relationship, such as emotional intimacy. Phase 4, resolution phase. Genitopelvic pain and penetration disorder. Dysfunctions that do not fit nearly into a specific phase of a sexual response cycle and are characterized by enormous physical discomfort during intercourse and are called genitopelvic pain penetration disorder. Penetration disorder, vaginismus, characterized by involuntary contraction of the muscles of the outer third of the vagina. 1% of all women learned fear response. Genitopelvic pain, dyspareunia, characterized by severe pain in genitalia during sexual activity. As many as 14% of women and about 3% of men suffer from this problem, usually occur due to physical causes and sometimes psychosocial factor. The paraphilias. What is the meaning of paraphilias? Para means deviation and philias means what the person is attracted to. Paraphilias, recurrent sexual attraction to unusual object or unusual sexual activity for at least 6 months. Deviation means para in what the person is attracted to means philia. Should only be diagnosed when the cause marked distress or done with non-consenting person. Transvestic behavior, cross-dressing for sexual gratification, rarely marked by distress or involved non-consenting person. Divided categories based on source of arousal, sexual attraction based on intimate object, sexual attraction based on children. Number 1 of paraphilias, fetishistic disorder. Reliance on an intimate object or unsexual part of body for sexual arousal. For example, shoes, stocking, underwear, hair, feet, and so on. Occur most often in men. Object often necessary for sexual arousal. Attraction to object irresistible and involuntary. And often occur with other paraphilias. Pedo-hemophilic disorders and incest. Pedo means child. Hebe means puberty. Philias means attraction. Pedo-hemophilic disorder, sexually arousing urged fantasy behavior involving sexual contact with pubertal or pubescent child. Offender at least 18 years old or 5 years older than the victim. A child's pornography is widely used. Victims usually known to be pedophile. Neighbors, family member, friends, clergy. Most pedophilias does not involve violence other than the sexual activity. Incest, subtype of pedohemophilic disorder, most common brother and sister, less common but more pathological father and daughter. Incest taboo, almost cultural universal, genetic adaptive, offspring of father-daughter or brother-sister have a greater likelihood of inheriting pairs of recessive genes with possible negative biological effect. Voyeuristic disorder, sexually arousing fantasies, urges, or behavior while observing others who are unclothed or engaging in sexual activities. Almost always men. Excitement comes from knowing the victim is unaware of that. Element of risk is important. Seldom result in physical contact. Orgasm achieved by masturbation. Victim unaware that they are being watched. Exhibitionistic disorder, intense desire to obtain sexual gratification exposing one's genitalia to unwilling stranger. Victims can be children. Seldom result in physical contact, usually involve a desire to shock or alarm victim, often comorbid with voyeuristic and fetishistic disorder. Fetishistic disorder, sexually oriented touching or non-consenting person. The individual rubs his genitals against a woman's body, often occur in crowded subway or other public places. Sexual sadism and sexual masochism disorder. Sexual sadism disorder, intense and recurrent desire to obtain or increase sexual gratification by inflicting pain or psychological suffering on another person. Sexual masochism disorder, intense and recurrent desire to obtain or increase sexual gratification through receiving pain or humiliation. Asphyxiophilia, sexual arousal by oxygen deprivation can result in death or serious brain damage. Debate over inclusion in DSM-5. Etiology of paraphilias, neurobiological factors, male hormone and androgen. Almost all with paraphilias are men, do not have unusual level of testosterone, classical conditioning, operant conditioning, history of childhood physical and sexual abuse, alcohol and negative affect are common triggers. Cognitive distortion, that's to say, because the child doesn't run away, she must want me to fondle her. Treatment of paraphilias, enhance motivation. Why no motivation for treatment? Because of denial and minimization of the problem often present. Some blame the victim, lack of motivation for treatment and drop out of treatment. Cognitive behavior therapy, CBT, this including aversion therapy, covert sensitization, counter distorted thinking, often combined with social skills and empathy training. Biological treatment, castration used in the past, now using medication as hormonal agent to reduce androgen and SSRI. Gender dysphoria. According to DSM-5 criteria, people with gender dysphoria persistently feel that they have been assigned to the wrong biological sex and gender change would be desirable. The DSM-5 categorization of this disorder has become controversial in recent years. Many people believe that transgender experience reflect alternative, not pathological, ways of experience one's gender identity. Others argue that gender dysphoria is, in fact, a medical problem that may produce personal unhappiness. DSM-5 checklist. Gender dysphoria in adolescent and adult. Number 1, marked inconsistency between one's assigned gender and one's experienced gender, lasting for 6 months or more, consisting of two of the following: marked inconsistency between one's experienced gender and the primary or secondary sex characteristic, a strong desire to be rid of one's sex characteristic, a strong desire for the sex characteristic of the other gender, a strong desire to be a member of the other gender, a strong desire to be treated as a member of the other gender, a strong conviction that one has the typical feeling and reactions of the other gender. Number 2, significant distress or impairment. Gender dysphoria sometimes emerge in childhood and disappear with adolescent, but in some cases develop into adult gender dysphoria. Many clinicians suspect biological, perhaps genetic or prenatal factor. Abnormalities in brains, including hypothalamus, are potential link. Thank you.